Now we move to our next talk by Dr. Sriraj Alapati. She's going to present, Dr. Sriraj is going to present on surprise cystic mystery. Dr. Sriraj.
And I request all the speakers to please come in front so that they can move on quickly for the next presentation.
Good evening, everyone. I'm Dr. Sriraj from KMC Mangalore, presenting a case, surprise cystic mystery. So, a 46-year-old female presented with a chief complaint of left eye lower lid swelling since 3 days, which was associated with pain and redness. There was similar history 3 months ago, which relieved on medication. Patient has history of pets at home. There is no history of trauma or eye surgery or dental caries or sinusitis. So, patient went to a local hospital for the same and was started on tablet amoxiclav and tablet levocetirizine. So, patient is status post mastectomy, radiotherapy, chemotherapy for breast carcinoma 1 year ago. There is no history of diabetes or hypertension. On local examination, there was left eye lower lid edema with approximately 2 into 2 centimeters swelling palpated 3 centimeters lateral to the bridge of the nose and 1 centimeter below the lid margin with well-defined margins, which was hard in consistency, mobile, associated with mild tenderness and a local rise of temperature. So on ocular examination, head posture was normal, gaze was orthophoric, and extraocular movements were full and normal in both the eyes. Visual acuity was 6/6 in both the eyes. Anterior segment was normal in the right eye, and in the left eye there was lower lid edema with 2 into 2 centimeter swelling, as mentioned above. Fundus was normal in both the eyes. So patient was provisionally diagnosed as left eye preseptal cellulitis and was started on tablet amoxiclav, ranitidine, serratiopeptidase, and diclo for 7 days. On follow-up, despite a reduction in lower lid edema, a distinct mass was felt on palpation, so patient was advised for CT orbit for further evaluation. So this is the CT showing axial view and coronal view. So in the CT orbit, there was left preseptal heterogeneously enhancing soft tissue swelling with enhancing hypodense area in the center, seen adjacent to inferior orbital margin, which was suggestive of abscess, query, and or it could be granulomatous infection. So patient underwent left lower lid excisional biopsy under local anesthesia. So on histopathological examination with a 40x magnification, it has shown a thick cuticle with circumferential muscular layer and a surrounding giant cell reaction, which was suggestive of dirophilaria. The first slide was 40x magnification, which shows numerous eosinophils. And the next one is with the 10x magnification, which shows a nodular lymphoid aggregates with germinal center. So this is the post-op pictures of the patient with POD 1 and 1 month follow-up. So moving on to the discussion, domestic and wild mammals as dogs, cats, and foxes are the natural host for dirophilaria and is accidentally transmitted to humans by Culex, Aedes, and Anopheles mosquito bites. 4 species are transmitted to the humans. Dirophilaria immitis, which causes pulmonary lesions, and Dirophilaria repens, tenuis, and utsi, which infects the subcutaneous tissue. So the ocular manifestations of dirophilaria include periorbital, that is lids, orbital, subconjunctival, and intravitreal. So conclusion, this is a rare case of parasite presenting as preseptal cellulitis. A well-defined mass in ophthalmological examination, such presentation should be maybe considered for a biopsy. Thank you. These are my references.
Did you even think of anything else before doing a biopsy on this case, considering her history of breast carcinoma?
Oh yes, sir. That's the reason we have taken a excisional biopsy. So could be any mets or...
No, I think maybe a PET scan or something, like whether it's a mets or not. I mean, biopsy is not the way to go.
Yes,
for if it was, you were lucky that it was not a mets.
Yes,
but there was nothing clinically to suggest that it is not a mets.
Yes,
of course, except the inflammation, which is neither here nor there, right?
Yes, ma'am.
So what made you think that it is not a mets and let's go in and do an excision?
Ma'am, when we did a CT, it has shown it was like some granulomatous infection. It was with a CT. CT orbit was done.
CT, can you really make out whether it's a granulomatous infection?
No, we can't make out, but they have given...
Can't really make out, it's a little dicey to touch these patients like that.
Yes, ma'am.
maybe after a PET scan has been done, and then you go ahead and touch these patients.
Yes, ma'am.
Uh,
Actually, she has a history of similar kinds of 2-3 episodes. Like since 1 year, she's getting preseptal cellulitis. She's using some antibiotic and
Yeah,
it's getting resolved.
that is a pointer in the direction of a parasitic infection, recurrent lid
Recurrent,
swellings, right?
recurrent,
That is
so-
a pointer towards your diagnosis, but nothing more than that.
Yes, ma'am, nothing
Right?
more. Yes.
Okay.
I have only one question that you mentioned in your history the patient has recurrent episodes
Yes, ma'am.
before they report it to you. And you also had a trial of amoxicillin clevenaceid. Shouldn't the radiological investigations be done before you proceed with antibiotic trials?
Actually, previously, the 2 episodes she was treated was in a different hospital. So the 3rd episode, she has come here. So we started on antibiotics. After that, we felt like the surrounding edema was resolved, but the mass was distinctly present like a lump there. So then we ordered for a CT. When we talked with the radiologist, they told it could be abscess or it could be some granulomatous infection. They told query. So then we have taken an excisional biopsy and sent for the histopath. Then it turned to be a worm in that.
That is what exactly my question is, that shouldn't we do a radiological investigation before you give a trial of antibiotics, because the patient has already been treated outside?
Yes, we have to do.
No, I think you guys gave the antibiotics first, right?
Yes.
Or is
We also has given antibiotics.
it was given outside also?
Outside it was started and we have continued for like 5 more days.
Because sometimes in acute inflammation, if you do it CT right away, you may not get a very clear picture. Sometimes we may
Yeah,
wait for
exactly.
some time.
But they have,
like
you
5
see, already
days.
had been treated outside.
No, actually we have done after the preseptal cellulitis has been resolved, inflammation has been resolved, then we have done
Then
the CT.
they went ahead. Because
Not
otherwise the
during that.
picture, you won't get a clear picture,
Clear, yes.
right?